Welcome and thank you for joining us for Compleatrix webinar series. Please note the information shared today does not constitute legal advice and is for educational purposes only. To sign up for our next session, the top 5 OSV conditions and why technology is essential to continuous HRSA compliance, please go to next.fqhcwebinar.com. Today's webinar, Contracts in an FQHC, Are Your Contracts Compliant? We are delighted to welcome Jeff Adest, a partner and director at Garfunkel Wild PC, as our presenter. Jeff has over 20 years of experience representing numerous FQHCs and other healthcare providers in all aspects of their operations and regulatory compliance. He regularly counsels FQHCs and lookalikes on many complex and day-to-day issues. Jeff, I will now hand over to you.
Okay, thank you. It's a pleasure to be speaking to everybody today. For those of you who have heard me before, many of you on the phone I've spoken to you before. For those who have not, nice to meet you, at least over the phone. I'm supposed to get a couple of technical things out of the way before I get started. Everyone should know, so you don't have to be sitting there with your phones and taking pictures of the slides. The webinar is being recorded, and we will be sending out the recording as well as the slides hopefully in the next couple of days. We actually have a YouTube page or something like that, so apparently I am a star on YouTube. Has not really done much for me in terms of my kids thinking I'm any cooler, but apparently there are a lot of recordings of me, and this one will be up, like I say, in the next day or two. Okay, so before we get into the topics for today, just want to let you know that there are a series of webinars that will be coming up probably starting in November and continuing during the following months, covering a variety of topics which are listed here. One of the things I just want to point out is HRSA has started doing FTCA site visits, and if you've gone through a regular OSV and think that a regular OSV is bad, the FTCA review is bad on steroids. They are very, very detail-oriented and want to see a lot of things that don't seem to fit with any compliance manual or only any site review guide that is out there. But we'll leave that for a different webinar. Okay, so we have a very full agenda today. You can submit questions. I just want to let you know up front that I'm not sure there will be time for questions because we have so many things to cover. But if you submit the questions and we do not get to them during the webinar, we will respond to them after. The questions are private, not shared with everybody, so you don't have to feel like by asking your question, everyone's going to know that you don't understand what a contract is, and it's okay to ask your question. Okay, so this is a topic that is, to my knowledge, not one of the typical topics you hear when you go to NAC or you go to some other conferences. Typically, things you talk about are things like OSVs. In terms of contracts, we thought this was an interesting thing because contracts are involved in pretty much, everything an FQHC does, whether officially or not. And so we just wanted you to have a better understanding of what those contract requirements are and how contracts work. So just to give you a background in general about contracts, I'm taking 3 years of law school and putting it into 3 minutes. So it's going to be very high level. But just to use an example, you walk into a store and you want to buy a product, right? And so the product is on the shelf and it says that it's $3.50. What's happening at that point is the owner of the store or the chain is actually making an offer to you that if you want to pay $3.50 for this product, they will sell it to you. Now, when you go and you take the product, you bring it up to the register and you pay for it, you're accepting it. So that's the first two. Those are requirements for a contract. Have the offer and acceptance, right? So I imagine you, like me and everybody else, gets all these offers in the mail from people, all these products where if you sign up for it, you'll just sign away your whole life. You don't have to worry about it. And those are offers by the company, right? But if they put into that thing something that says that if you don't reply within 10 days, you've automatically been deemed to accept, that doesn't work. The reason why they don't do it is because they understand it doesn't work because you actually have to do something to accept. You also need to have intent. which means that if you are drunk and someone sticks a piece of paper in front of you and you sign the paper and have no idea what you're signing, even though you signed the contract, you are not considered to be bound to that contract, assuming you could prove that you were drunk when you signed it. Okay, the biggest thing that really comes up in contracts is consideration. So this is more what the attorneys know and not necessarily a layperson understands, so I just want to spend a minute on it. Consideration means that party A is giving or doing something for party B in consideration of party B agreeing to do something for party A. So let me take an example. Somebody walks in, you have a patient who walks in. Now in FQHC, you generally don't have many very rich patients, but theoretically, you have someone who walks in and says that when they promise you that they're going to give you a donation of $1,000. If you have not given them something in exchange for that $1,000, and the promise is just that, it's only a promise, it's not legally enforceable. So if a hospital comes to you and says, we're going to give you a grant, yeah, go open a new site, we're going to give you a grant. Unless there's a contract that says that you were agreeing to open the site based on them saying they give us a grant, just the fact that they came ahead and said they're going to give you a grant does not make it binding because you didn't give them anything back for it. So even though you signed a piece of paper, even though you have a formal agreement, you cannot enforce that agreement because it was nothing you gave them back in exchange for them agreeing to give you the grant. So we have this on a slide later. I guess one of the things, the overarching theme for today is making sure you have appropriate contracts where needed. And then I will add to that, making sure that you have an attorney who's reviewing it and preferably an attorney who understands FQHCs. Because as we go through some of the examples, I'll point out to you that we have many circumstances where people come to us and say, I have this contract, what could I do with it? Or look, they told me this is what happened and it's supposed to be in the contract. And we look at the contract and it turns out that it's missing critical information for you to be able to enforce your rights, and then you end up being in a situation where you're stuck. Okay, we get lots of questions. I don't know where it came from, but I'm constantly getting someone telling me, no, I don't want a contract, I don't want an agreement, I only want an MOU or an MOA. So we put up here on the screen different types of contracts. As a general course, term sheets and letters of intent are just things where you're talking about what the basic terms will be, but they're not generally enforceable contracts. But all the other kinds of contracts are just as enforceable. There's nothing better or worse about an MOU than there is about a full contract that's 30 pages long. People tend to do MOUs when they think they want it to be a shorter agreement, but all the requirements of agreement need to be in it, and they're just as enforceable. And so if you are being pushed for one versus the other, understand that legally they are, like I say, just as enforceable as the other one, and there's no reason why you have to do an MOU as opposed to doing a full agreement. We often find that when people try to do things like MOUs, and don't get me wrong, we use them on many occasions, but we often find that FQHCs, when it's coming to an MOU, won't end up sending it to their attorney because it's just a short contract and it's very straightforward. I could read it. And we often end up finding that there are things that are missing when you do an MOU that you really need to be there, that would be there generally when you did a full agreement. I know no one wants a 20-page agreement, but you could have a full agreement that's 3 pages long. Maybe it's a page longer than what the MOU would be, but if it protects your rights, it's important to be able to do that. Okay, so why do you need a contract? So very often people will say, okay, the person said they're going to do this and I'm just going to rely on it. So I'm going to jump to the last one for a second and then come back up. If for no other reason, you need to have a contract because HRSA requires many of the contracts we're going to talk about today. But even if HRSA did not require those contracts, I would tell you that you still want to have them because if you don't have a written contract, it's very hard to know a year later what was the intent of the parties and what were you getting for your services and what were you paying for your services. I will tell you that one of the biggest problems we see in contracts is that, so it's a service agreement where some vendor is going to provide you with the service, and when I come to see what the service is, it's just very broad. They're going to provide you with billing services. They're going to provide you with IT services. but if it doesn't have any detail, then it's almost impossible to enforce. Where you come along and you say, they promised me that they would get the bills out within 3 days. And I'm going to look at the contract, and the contract just says they're going to do billing. It doesn't say they're going to get it out within 3 days. You can't enforce that they're going to get it out within 3 days, and now you're stuck because you only did this because they said they're much better than the next company, much faster. Well, if the contract doesn't say it, then you don't have a basis to be able to go enforce those types of provisions. Okay, so what's in a contract? I'm not going to hit every point on the screen here, but I'll tell you some important points. Like I talked about, description of service is very important. Payment terms are very important, right? We often see that you talk about it will pay you this fee, but it doesn't break down. Is the fee going to be paid monthly? What day of the month it has to be paid on? Are there things for you to be careful of? Is many times, with vendors, they will require, if you're late on your payments, that you have to pay interest. Many agreements require that you pay within 30 days. Most FQHCs that I know are not able to necessarily pay within 30 days, so you want to try to negotiate for 60 or 90 days, and you want to negotiate there's no interest if you don't make timely payments. Term and termination are obviously very important. So something that I think attorneys understand and not necessarily do all lay people understand is the term of the contract is almost irrelevant, absent regulatory requirements we'll talk about later, but the term is almost irrelevant. It really goes by the termination provision. If I have a 5-year contract, but in the termination provision, it says it can be terminated without cause on 30 days notice, then what that really means is to have a 30-day contract. And so, we often see people getting crazy about, no, it can't be 5 years, it can't be 3 years. You got to look at the termination without cause because that's really going to govern. I understand from a feel perspective, it feels better to know that I have a 3-year contract. But again, if you're getting a new EMR, now typically they don't want it because they want longer. If the EMR agreement has a provision in it that says that the EMR company can get out on 30 days notice, you've now spent millions of dollars to put in this new EMR, and on 30 days notice they could get out, and now you have lost all your money because even though the term says 10 years, they're allowed to get out on 30 days notice. Okay, so when you're negotiating contracts, it's important to prioritize for yourself as to what you're looking for out of the agreement. So I will tell you that when I first started as an attorney, 25 years ago, one of my first assignments was someone gave me a 3-page contract to review. We started as a new attorney, they give you a contract to review and say, come up with comments. So I reviewed that contract and I wrote a 7-page memo of problems that I found with the 3-page contract. And I went to the senior attorney I was working with and showed it to him, and he's like, every single one of these comments on the 7 pages are very valid. But he's like, but on a 3-page contract, we can't provide 7 pages worth of comments. So you need to figure out what's really important to you and what's not that important to you. And again, this goes to understanding FQHCs and what your regulatory requirements are, because what might be important to a business in the community, it might not be the same thing for you because you need to have certain regulatory requirements in it, but you also need to be realistic in negotiating your agreements, and you need to be using attorneys who are realistic, right? Thankfully, he didn't let me send out that 7-page memo, but if you're getting a 20-page memo of comments from your attorney on a contract, then you need to feel like the attorney doesn't have a lot of work to do and is trying to at your expense, be able to get a lot of billable hours, right? When we negotiate contracts, we'll come back and talk about what's really critical and what's not. And obviously each contract is different, but, sitting there and making changes to boilerplate language is usually not worth you spending your money on. It is very important, like I said earlier, that the contracts be in writing. Just verbally agreeing to things. Now, I will say that verbal agreements are generally enforceable, but if you don't have it in writing and can't come back to what it is, like I mentioned earlier, it's very difficult to be able to make sure that your rights are being protected. Okay, so overall with regard to contracts, I'm assuming that every FQHC on the phone, or substantially every FQHC on the phone, has gone through an OSV at some point, or if not, then you must be new and you will be going through one soon. So one of the biggest issues that we have when OSVs come around is HRSA is a very big stickler for the contracts, for the agreements. Show me this agreement, show me that agreement, show me all the different kinds of agreements. And very often what ends up happening is, I don't want to say running around like a chicken without a head, but that's pretty much how you end up describing it, that we now have to find dollar contracts. So some of them are in the office of the HR director, and some of them are in the CEO's office, and some of them are in the CFO's office, and some of them, you know, the IT person left 2 years ago, and we have no idea where those contracts are. And now you have to sit there and start trying to piece together many different agreements. So my strong recommendation is that you have a system that you can use to be able to track those agreements, right? You know, in the old days, you would keep them all in a hard file. I think nowadays people don't necessarily keep hard files anymore. So you need to have some software or some system out there where you could keep track of the agreements and don't have to be running around preparing for the OSV, right? As you all know, preparing for the OSV, there are so many other things you need to do anyway. You know, having to gather contracts or other relevant documents should not be something that you have to spend a lot of mental energy on. Okay, so what kind of agreements apply to FQHCs? So I'm going to start first with the specific agreements that are required relating to your Form 5A. So as you all know, Form 5A is each FQHC is required to either directly or by contract provide a full list of services, you know, approximately 20, 25 services. For most FQHCs, at least a handful, and some of them a lot more than a handful, the FQHC does not directly provide, and so it needs to arrange with someone else to be able to provide them. So what HRSA says is, again, you have to fill out your Form 5A, and I will just throw out a free tip for you. Before you're having an OSV, it is extremely important to go back to your 5A. We have done, you know, maybe in the last 2 or 3 years, we've helped 30 or 40 FQHCs prepare for their HRSA OSV, and we have never gone in and found an FQHC that did not have things that needed to be changed on their Form 5A. Partially, the reason for that is because HRSA changed the rules 2 years ago, the new compliance manual, as to how the forms need to be completed. So I would strongly recommend you go back and look at it periodically. Okay, so the 3 columns on Form 5A, the first column is you provide it directly. The second column is that you provide it through a third party where you're paying them for it. And the third arrangement, the third column, is that you have an outside provider that you're referring to. And we're going to go through some of the requirements relating to each of them. Okay, there's also hospital coverage arrangements, which you need agreements for, and we will go through each of these now. Okay, so I'm going out of order for a second. I'm going to column 3 before column 2 because most FQHC contracts end up being, for Form 5A, end up being in column 3 rather than column 2. So column 3 is the typical example is you don't provide lab services or radiology services. So you're sending out the labs and the radiology. So what HRSA says is that you need to have a written formal agreement for those referrals. Now, one of the things that HRSA changed, and again, I'm going to give you some free advice here, is it used to be that for every lab you referred out to, you need to have a written agreement with. What HRSA now says is that you need to have one formal agreement for each item on column A, in column 3 or in column 2. So if you have 3 different labs you refer out to, you're only actually technically required to have one agreement. But the way that works is that when HRSA comes, so I'm just going to pick, if you have that agreement with Quest, right? So when HRSA comes, you have to tell that you tell them we have an agreement with Quest. If you tell them, no, that we regularly send our patients out for lab services to Quest, LabCorp, BioReference, and 3 other labs, then they're going to ask you for a referral agreement with all of them. And what that means now is you've just increased your workload because you now need to have, 3 or 6 separate referral agreements with labs rather than just one. Now, obviously, if you are regularly sending out to 3 different labs, I'm not suggesting that you lie to HRSA. but if most FQHCs, in my experience, for lab, radiology, things like that, you send out 90% of your patients to the same place, and then there are some stragglers who say, I don't want to go there, I want to go someplace else, and that's fine. What HRSA says, again, is if you have a formal arrangement with them, then you have to have a written agreement which meets the requirements. If you don't have a formal arrangement, then you do not need an agreement. I will tell you, and again, this is going to the FCCA survey. In the FCCA survey, they take a different position, which is they want to know everyone you're sending out, and they want you to have a written agreement with everyone. So everything I just said, you have to ignore if you're having an FCCA review. But if you are, then this is, like I said, this is not the webinar for it. We'll have a separate one, or you can reach out to us to talk about it. Okay, so what do they want you to have in that agreement? Right, so this is like a place, we're going back to my earlier example, people like to use MOUs instead of using written agreements. And again, that's fine, but when you're having the MOU, you have to have all these requirements in it. So often we find that the lab agreements that are sent out by the national labs do not meet these requirements. So if you're just signing their lab agreement, you probably are not going to be in compliance with these requirements. So just going through quickly. Okay, yes, there has to be something in there that talks about how the referrals are going to be made and managed. The process for tracking the results back, right? So you're going to tell me, what do you mean? The lab sends us back the results. Of course, the lab sends us back the results. How else do we take care of our patients? And I'm going to tell you that that's great. But again, not coming from me, coming from HRSA. If it doesn't say in the agreement that the lab will send you back the results, the agreement is not going to be compliant. Okay. Probably the most difficult one is the next bullet point down, sliding fee, right? So we all understand that most FQHCs, the overwhelming majority of your patients are either Medicaid or self-pay. Now, if I'm a standalone radiology business in the area, I am not really looking for Medicaid patients. I'm definitely not looking for self-pay patients, but I'm probably not looking for Medicaid patients also, because right, we all understand that as an FQHC we get enhanced reimbursement, but for the standalone radiology business down the block, they don't get enhanced reimbursement. So for a Medicaid, doing an X-ray for a Medicaid patient, they may get reimbursed $12. And so unless they don't have, unless they have empty slots and have nothing else to do otherwise, if they are generally full, then they are not interested in the Medicaid patient. And so the problem comes up, okay, so I want to refer my patients someplace, but no one wants to take those patients and as a general course. And now on top of that, I'm telling them that for the charity care or the patients without insurance, they have to apply a sliding fee. Now, I don't want to mislead everybody just for a second. On sliding fee does not apply only to patients without insurance. Hopefully you all know that HRSA changed the rule 2 years ago, and sliding fee could apply to patients with insurance. But for purposes of example, I'm just going to refer to them as being patients who do not have insurance. So when you go to Joe's Radiology down the block and say, I want you to take my patients and apply a sliding fee, Joe probably slams the door in your face. Now, we all understand that's the way it works in the real world, but we all understand that HRSA does not necessarily live in the real world. And so in the HRSA world, everyone is absolutely willing to sign the sliding fee agreements. So what we tell people is go to the hospital, and all hospitals are required to have charity care policies. And so the hospital can apply its own charity care policy, does not need to apply your sliding fee policy. Now, we run into a lot of problems with this because I think there are attorneys out there who are advising that you need to have language in there that says that the hospital is going to apply your sliding fee, or that its sliding fee policy is at least provides at least as good discounts as your sliding fee policy provides. That is technically true. But in real life, our experience has been countless times that if you have in the agreement, the hospital says they have their own charity care policy and they'll apply that, HRSA will accept it. So trying to go to the hospital and get them to change their sliding fee policy or their charity care policy for your patients is going to be impossible. So I would tell you that as long as you have language in there that says they're applying their own policy, you're okay with that. The last bullet point is something, again, relatively new, and I think HRSA was trying to do something good and ended up, as part of doing something good, adding a burden on you as well. So you all know that when you do credentialing, right, it's a pain to credential and privilege providers. And what HRSA changed in the new manual is that if you are contracting, for example, with a hospital, and the hospital credentials the providers, that you don't actually have to credential them as well if you're leasing them from the hospital, which is one of the arrangements we're going to talk about in a few minutes. So what ends up happening is you could just put language into the agreement which says that the hospital will credential its providers, and therefore you do not need to credential the providers. However, what HRSA has now said is that even if you're not getting providers from the health center, from the hospital, you still need to have language in your agreements that say that the entity or the hospital is going to be credentialing and licensing its providers. Now, again, that's not a big deal because they do it, but it is a big deal in terms of making sure you have that in the agreement. Okay, column 2 contracts. So historically, very few FQHCs had column 2 contracts because generally if you're referring somebody out for a lab or radiology or things like that, you're not paying for it. What changed recently is that HRSA now takes the position that if you are contracting with someone to provide services, now that could be you're contracting with the hospital to send the doctor to you, or you're contracting directly with the doctor, but you're paying them on a 1099 as independent contractor instead of on W-2 as an employee. And they're coming and working in your office, HRSA says you still need to list them in column 2. So again, you have a podiatrist who comes to your office 2 days a week. You pay him on a 1099 basis. You need to add podiatry into column 2. In addition to adding podiatry into column 2, you need to have a column 2 compliant contract. And the column 2 requirements are actually greater than the column 3 requirements because in addition to being able to document and acknowledging about sliding fee, one of the other things that is required is that you have to have language in it that says that the independent contractor or the hospital will give you the data necessary for you to meet your federal financial and programmatic reporting requirements, and a process for record retention, audit, and property management. Now, I understand that you're all probably throwing things at the screen at this point and saying, this doesn't make any sense because they're not doing it. They're working on our site. They don't have separate records. They don't have anything they're going to give us to be able to do it. And I'm going to say to you that I agree with you 100%. Having said that I agree with you, HRSA says you must have it. So I will tell you that one of the things I do on a regular basis is try to explain to a column 2 contractor why we have to have this language in, even though it doesn't make any sense, and try to explain to them that HRSA requires that we have to do it. But like I say, you need to be able to put that language in, regardless of whether or not it makes any sense. Okay, hospital coverage agreements. So depending on how your FQHC functions, right, many FQHCs, their providers do not go to the hospital at all. There are some where the providers go and do deliveries or go and, and will check on newborns or, will go in for pediatrics, things like that. But most FQHCs do not regularly see all their patients who are admitted to the hospital. And so what HRSA says that you need to have some kind of continuity of coverage arrangement so that when your patients go to the hospital, there is somebody there who is going to take care of your patients and report back to you about the patients. And so really this kind of falls into the column 3 arrangement, but sometimes yes, sometimes no. But there are some additional requirements that go with it, which is, again, the second bullet point here is making sure that you're getting the discharge follow-up instructions and other results. Now, what I'm talking about today is just the coverage arrangement. I am not talking about hospital tracking, which has its own set of requirements. But what people sometimes get confused is hospital tracking today only applies to patients that you physically sent to the hospital, right? The patient was sitting in front of you, said, the doctor said, you got to go to the hospital right now. But if the patient went by themselves, you do not have to track. However, you need to have a hospital coverage agreement that covers all your patients, including the patient who went by themselves, and you still need to be getting information back from the hospital with regard to that patient. Okay, so procurement. So, as you know, you all get federal grant dollars. So I would, before I get to the requirements, I would strongly advise everybody that unless you're getting like a construction specific grant, but your regular 330 grant, use for salaries, right? You need the time and effort reporting for that, and that's fine, but don't use for procurement, because use it for procurement, you have to deal with all these rules, and HRSA comes in and does separate procurement audits, independent of the OSVs or FCCA reviews or anything like that. They will separately do procurement audits, and having all the right documentation and being able to show that you did everything is a real pain. So if you could avoid putting yourself into that situation, try to do it wherever possible. Okay, but let's say now you are using federal dollars to procure something. You got an equipment grant, you got a construction grant. So what do you need to do to comply with it? I will tell you that from everything in the compliance manual, this is the most dense piece to be able to comply with. Very difficult to have everything in order. Okay, so if you're doing procurement, right, so what has to be in the contract? I'm going to talk about how you do procurement in a minute, but what has to be in the contract, right? It has to be obviously like any other contract, a description of the activities or services or goods to be provided, right? But then there has to be something in there that says, how are you going to monitor their performance? So if you're having a contract that's building a building for you, it's not just you have in the contract something that says this is what they're going to do. You have to have a provision in there that says, how are you going to monitor what they're going to do, right? And they have to be able to give you the data you need. And again, some of the same things we talked about earlier, record retention, access, audit, property management. I will tell you that record retention is one that comes up as being a difficult thing to deal with in the procurement world, because you're dealing with a contractor who doesn't necessarily deal with healthcare. And so today they're building your building, and tomorrow they're building an office building, and the day after they're building, a restaurant. And so they're not used to necessarily keeping records for 6 years, which HRSA requires and most other agencies do not require. So that's something you have to work on with them to be able to be compliant with. Okay, so what are the procurement standards? So I'm not going to go through it in so much detail, but just overall, less than $3,000, you can pretty much do what you want. You still need to be able to keep an invoice or a purchase order or something to show you made the purchase. Between $3,000 and $150,000, you have to have at least 2 quotations, right? It could be an internet search, but this is the place where we find the most problems with regard to keeping records, because so you needed to buy something today, or you need to buy a piece of equipment that was, or some other product that was $5,000. You go on the internet, you look for 2 quotes, you look for 3 quotes, and then you go and you buy it from one of them. Do you print out the papers and keep them and stick them in a file? The answer is most of the time not. But what HRSA says is you actually have to do that. You got to print out all those pieces of paper and stick them in a file and keep them. Okay, sealed bids, competitive proposals, those are the things that are more typically used. HRSA does not mandate the terms of how you do it, right? So it does not mean that you necessarily have to be the lowest bidder, even though it says it up here, because you could have other conditions, right? If the lowest bidder is someone who does not have experience, then you could say, I'm not going to pick that bidder because I don't think they'll be able to do it. It's got to be someone who meets all of your requirements. Sole source is something that's not typically used in the outside world, but actually is used more than you would think in the FQHC world, because you're getting a grant for IT products. And now you're theoretically going to go out and bid that, but how are you going to bid it? Because you already have an EMR, and your EMR company is the only one who could actually give it to you and make it work together with your existing EMR. And so bidding it out to the street won't help you any, because it won't work. So in that case is where you could use sole source, but if you're using sole source, you need to have strong documentation as to why sole source was the only thing that made sense. Okay. So now I'm going to get to other agreements that are not HRSA specific, but that would typically come up in the FQHC world. So one of the things that I have often spoken about, to people when you talk about FQHCs is, so I don't know anyone who's on the phone right now. I can't see who's on the phone, so I'm not picking on anybody. But my experience has been that many FQHC CEOs are within 5 or 10 years of retirement and do not have a clear succession plan. So that'll be the subject of a different conversation to talk about having succession plans, different webinar potentially. But what that means is if you're within 5 to 10 years of retirement, are you thinking about what's going to happen when you retire? And I have found, for whatever reason, that in the hospital world, every hospital CEO has a contract. In the business world, any large business, the CEO has a contract. For some reason, in the FQHC world, many of the CEOs do not have contracts, and if they do have a contract, it doesn't address what's going to happen to them after they retire. Are they entitled to severance, right? You've taken this FQHC. When you started, it was a $2 million entity and had 1 site. Now you've been here for 30 years, and you have 9 sites, and you're a $50 million entity, and you're walking away, and when you walk out the door, you don't get your salary anymore, and you get nothing for it, right? In the business world, outside of FQHC, you'd be getting a golden parachute, you'd be getting $12 million, some big number, you're getting shares, stock options, things like that. None of those exist in the FQHC world. What exists is severance, and so I strongly encourage you to have an agreement so that you could address your own internal severance. So that's on the personal side. On the HRSA side, HRSA does like to see CEO agreements. It's not an absolute requirement, but they do like to see it, and so I think it's important. It's also important to have agreements for your physicians or dentists or other that level providers. And we'll go through what some of the requirements are. There are some FQHCs that have employment agreements for other levels of senior management, like the CFO, for example, or some of them will have for nurse practitioners or PAs. So or APNs, depending on what state you're in, what you call them. But just to point out, the agreement that you have for an NP or an APN to have a collaboration agreement is completely different than the employment agreement. The collaboration agreement basically says they have some physician who's going to be sitting with them once in a while and supervising what they're doing. That is separate from an employment agreement, and having one does not necessarily cover the elements of the other. So what would typically be an employment agreement? So besides all the things we talked about earlier, other things that would be in there is compensation, right? So every agreement has payment, but the compensation, hopefully many of you are going to a structure whereby you have some kind of productivity or incentive bonuses. If you're not, feel free to reach out and we could help you with some ideas for that, because FQHCs are designed to take care of the totality of the patients. You still are businesses, and for whatever reason, we have found that in FQHCs, if you do not have productivity standards, your physicians tend to lag far behind, national average for all physicians overall. And when you have productivity bonuses, they tend to see a lot more patients. We also are doing a lot of productivity bonuses, or a lot of bonuses that are tied to quality of care and incentives and meeting UDS measures and things like that. So it's not just about volume of patients, it's about the quality of services, which obviously is very helpful for all your QA and FTCA and risk management activities. Okay, we talked about severance. For lookalikes, right, so for regular FQHCs, you're going to have FTCA coverage. You don't need to worry about malpractice insurance. For lookalikes, you need to make sure that you're worrying about malpractice insurance and who's responsible for it. Okay, assignment of right to bill. So as you all know, FQHCs in general get paid a global rate for everything that's done for that visit. If you're hiring a physician who's coming out of private practice, they don't necessarily understand that, and we have found many times that when a new physician starts, they think they can submit their own bill. You need to be clear in the agreement they cannot submit their own bill, and needs to be clear that if there are incentive payments out there which go with this, that you're building into the contract that you, the FQHC, get that incentive payment rather than the physician getting it. Okay, restrictive covenants. So you have a physician who comes to work for you and is there for 5 years and now decides that she's going to move across the street and open her own practice and take all the patients away. If you don't have restrictive covenants built into your agreement, you will not be able to protect yourself and prohibit her from going across the street. Now, many FQHCs say to me, I'm not really worried that a physician is going to want to go into the private business of Medicaid patients, and so I'm not worried that they'll go across the street. And so what I say to that is I hear that in certain circumstances, but what you need to worry about is the FQHC that's down the block from you stealing that provider away and having all the patients go to their FQHC instead of yours. So I think restrictive covenants are very important in FQHC agreements. Now, if you're someplace where the closest FQHC is 200 miles away, then you don't really need to worry about it. But if you're in an urban area where it's 2 blocks away, that is a concern. Okay, grant agreements. Hopefully, many of you have grant agreements with hospitals, right? So the typical model that we see for a grant agreement with the hospital is the hospital has a clinic, and they come to the smart conclusion, based on you telling it to them or based on some other way they hear about it, that it does not make sense for them to continue operating that clinic because they're losing $3 million a year by operating the clinic. And so you enter into an arrangement with them where you will take over operating that clinic, you will add that site to your scope, and now going forward, they have this $3 million loss off the books. The problem is that even with you operating, it's still going to lose $1 million. So what you can do is have them give you a grant for the $1 million or some number like that, where for them it's worth it because before it was costing them $3 million, now it's only costing them $1 billion. And for you, it's worth it because you have a new site and you can take care of the patients, and they're giving you a grant to make sure that you break even. So we see these on a very regular basis. Does not have to be in that circumstance as well. It could be just a general. You go to the hospital in the community and say, look, we take great care of the patients, and by us doing our care in the FQHC and caring for the totality of the patient rather than just episodic care like the physicians in the community, we are helping you, hospital, avoid unnecessary hospital visits, right? So I always give this example. I'm going to say about 16 or 17 years ago, I had a kidney stone. It was at night, and I ended up going to the emergency room. Okay, I'll tell you in the end, I ended up having to have surgery to remove it. It was that big. But I'm sitting there in the emergency room at 2 o'clock in the morning, screaming like a crazy person, in agony, laying on the floor, banging and screaming. And I'm sitting there waiting while there are 5 people there who are there with their kids who have an ear infection and might have strep throat and things like that. And that's when they could come because they have no place else to go. And so they come there in the middle of the night to have their kid taken care of. So I can tell you that the hospital does not want the strep throat cultures and does not want the ear infections in the middle of the night. And so when you go to them and you say, look, we're going to expand hours, we're open from only until 5 now, but we're open until 7, but that costs us a lot of money to be able, because we now have to pay people overtime, give us a grant to do that. That's a good example of being able to get a grant, and you can get a grant for it. So when you have a grant, what goes into the agreement? Obviously, it's the amount. It's what the purpose of the grant is for. So sometimes hospitals will say to you, I'm going to give you a grant, but we know that in this community, pediatrics the care is very poor. So I want to give you a grant because I want you to go out and hire 2 new pediatricians. It is okay for the hospital to say that, and it's okay for you to accept a grant for that. Okay, very importantly, you want to make sure that there's nothing built in that where you would have to ever repay the grant or have to pay any interest on it or anything like that. It's yours and it's a full grant. It's not a loan. Here, term becomes very important because how long do they keep giving you the grant for, and making sure that it's not just going to be a 1-year grant and now you've taken over that clinic and great, but now in year 2 when you lose $1 million, how are you funding that? So you want to make sure that you're getting a long-term period on that without any ability to terminate without cause during the period. Okay, so there is very unusually, there is a specific safe harbor for FQHCs that basically says that anybody can give a grant to an FQHC for any reason, and it's very broad, even though the referral source, right? You might say to me, well, how could a hospital give me a grant? I refer all my patients to the hospital, and the answer is that they can give it to you, and there's, like I say, a specific safe harbor from the anti-kickback law that allows it. I've given you the elements of the anti-kickback law in the next couple of slides. I'm not going to sit and go through all of them. Just want to point out a couple of them to you. The most important thing is it must be in writing. If they give you a grant without a written agreement, then it goes straight to jail. You violate the anti-kickback law. So it must be a written agreement. The hospital cannot tell you, so even though you make referrals to the hospital, the agreement cannot provide that we're giving you the grant for pediatrics, like I said before, but in exchange for that, you have to send all your pediatric cases to the hospital. There cannot be any referrals conditioned on the grant. There might be an understanding that's the way it's going to work, and that's okay, but there cannot be anything formally in writing or otherwise that says you must make referrals because of it. Now, you also have to figure out, right, if the grant is just to give you money to be able to put money in your bank and not to be able to treat patients, that's not okay, right? The grant has to be going towards the treatment of patients or towards getting equipment to be able to help treat the patients or doing, to build out space, things that are ultimately going to lead to better or more care for the patients. There is a requirement for you as the FQHC that you have to give your patients notification they can go to any provider. So you need to make sure in real life that your physicians are not telling the patients, look, you got to go to XYZ hospital, right? You don't have to necessarily, we've had difference of opinion on it. Our position is that you don't have to be giving every single patient a piece of paper that says, here's 5 hospitals you can go to, and with 4 other hospitals besides the one giving you a grant. But you cannot be doing the opposite, which is telling them they have to go to that hospital. Also, something very important with regard to the hospital is the hospital cannot say that I'm only going to give this to your charity care patients, or I'm only going to give this to your Medicaid patients. The hospital has to make this if the hospital's running a discount for you, not a grant, but let's say they say that if your patients come, we'll give a 10% discount to any of your patients. That has to apply across the board to all patients. It cannot apply only to a specific category of patients. Now, obviously, if they have a charity care policy, the hospital could say, if you qualify for the charity care, we'll apply our charity care. But if they're giving you different pricing, then they can't distinguish between classes of patients. Okay, so professional services agreements or lease personnel agreements, right? So those are really basically the same thing. People tend to use one term versus another, but it's basically the same idea. It's that someone is sending you providers to provide services at your FQHC for which you're going to bill. So those providers will not be your direct employees. So we typically see this in the specialist context. So I will tell you, real life example. We had a hospital where the FQHC was sending all their cardiology patients to the hospital because they didn't have a cardiologist and they couldn't find anyone in the community who would send it, so they sent it to the hospital. The hospital actually picked up the phone and called the FQHC and said, I can't handle this. Your patients are overrunning my department. I will give you a cardiologist to come to your FQHC once a week for free. Just stop sending the patients, willy-nilly. Let's do it in a scheduled way. And now the FQHC actually got a cardiologist for free. Now, doing it for free might have an issue with regard to billing, but you could pay them a nickel, and then you're okay with doing it. So that's a good example. But there are a lot of benefits to you and to the hospital, right? So you're trying to sell it to the hospital. So for you, your patients can't get cardiology service, and now they can all of a sudden, right? You could bill at your enhanced rates. Depending on the state, you may be able to do a change of scope for that and might lead to an increase in your Medicaid rate. For the hospital, like I say, they don't have to have patients showing up in the emergency room when they don't want. Also, generally in the FQHC, you are not going to be doing the intensive services, the stress tests and things like that, which what the hospital really wants. And so when their provider comes and now the person needs a stress test, they'll end up referring the patient back to the hospital, and the hospital will gain what it wants out of it while you gain what you want out of it, right? Also, if you're not contracting with the hospital, just individual specialists, you go to the cardiologist down the block and say, look, I want you to come to my office. And he says, I don't want to take Medicaid. And so in many states, Medicaid is a site-specific thing. So he could come to your office and see Medicaid patients in your office, but still not take them in his private office. Okay, so just make sure, though, you think about change of scope, right, if you're adding that service, and think about whether you need any state approvals for it. The pricing can be very flexible. It could be on a session basis or a patient basis, and it fits into the safe harbor. Okay. There also is value-based potential. We're not talking about value-based today, but there is potential for you in terms of value-based dollars by having the specialist included in your panel. Okay, so what goes into the agreement? Again, scope of what services are going to be provided, what personnel are going to be provided. Now, there's this misconception that if you're getting a pulmonologist, it always has to be a Dr. Smith comes, right? It could be that there's a practice that have 5 pulmonologists, and in week 1, Dr. A comes, and in week 2, Dr. B comes, etc. It doesn't have to be the same person And now, if there are 5 people, you have to credential and privilege all of them potentially with or enroll them with the payers, but it does not have to be the same person. It could be different people. Again, making sure billing and collection that they understand that only you are going to bill and they're not. The compensation, like I said, you could pay them less than fair market value generally, as long as you fit it into the safe harbor, which is not that difficult to be able to do. Okay, vendor agreements. So these are the general agreements you sign that don't fit into any other category. So very often, if you're buying paper from Staples, right, I'm not going to tell you to go sign a contract with Staples, and you're going to do that hopefully through a purchase order system where you're keeping track of it. But if you are buying a new EMR, or if you're buying a new piece of equipment, you want to make sure that you have a written agreement, first of all, because you're getting warranties then, and second of all, because you want to be able to enforce your rights. So the standard equipment purchase agreement is 1 or 2 pages, and it's written in 4 size fonts and has 10,000 words on the page, and people just sign it. And we constantly have problems with people coming back to us and saying, I signed this contract where I had 10 copiers, and I'm stuck in it for the next 3 years. How do I get out of it? And they come to me after it's signed, and you know what the answer is? There's no way to get out of it. You're stuck with the equipment, and as you all understand, the second the equipment came out of the manufacturer and came to your office, the value is only 40% of what it was the day before. And so you're trying to sell it back to somebody or get someone else to take it, you're never going to get anything close to your money back. Or very often they use finance, like they'll have 2 separate companies, one that manufactures it, one that finances it, and the one that finances doesn't do anything but finance. And so when there's a problem, you want to go back to them, they say, what are you talking to me for? I'm just a finance company. So it is really important that you have someone look at those agreements, because it's a regular thing that we get calls from people who are stuck in those agreements and have no way to get out. Okay, other agreements, I'm going to go a little bit faster because I only have 8 minutes. Resident rotation agreements. So for many years, there was this view out there, I don't know why, that in many FQHCs that having residents is a terrible thing for the FQHC. They slow everything down, they cost me so much money in terms of productivity and things like that. And while some of that may be true, in fact, our experience has been that having residents is actually a very good thing for many FQHCs. First, most FQHCs that I know have problems recruiting. So having the residents, you're getting free labor, you're not paying for them, but once they come to work for you, they've now seen what it is to work in an FQHC, right? I'm sure that you've all experienced is when you leave work and you go out and talk to the rest of the world. Unfortunately, I don't know why, but if you talk to the rest of the world, most people have not heard of an FQHC, right? And so people in medical school haven't heard of it either. So a resident, you tell them, I'm going to go work in an FQHC, they have no idea what you're talking about. But now they've come to see how it works in FQHC, and they come to see that you take care of the totality of the patient, right? And they're still young, and they still believe in the mission. They haven't been working for 30 years and just want to get home as fast as possible. And so that's a great way to recruit them, because they now can sit there and actually take care for the patient the way they're taught in school to care for the patient. You also have that if they have loans, they could get loan forgiveness through the National Health Services Corps. You also could have visa candidates, right? These FQHCs are automatically considered to be HPSAs, health professional shortage areas, which is what visa candidates need in order to be able to work. They have to work in one of those. So that's another source of you being able to get physicians to work for you, and many residents are under visas. Now, obviously, if a hospital is sending you the residents, you can go back to them and say, yes, it will slow us down somewhat, so give us a grant, and usually the hospitals will be willing to do that because they want to capture the GME dollars, which are very valuable to them. Okay, so now you need to think about, what time frames you want to have. Do you want them there all day, or you only want them Tuesday afternoons? What specialties you allow, and the limits that you can have, what their effect might be on your productivity rate. So some states in the Medicaid program have productivity standards, that they want you to have, they value a physician as having 4,200 visits a year. And if the resident is only going to see, 1 patient an hour, they're going to mess up your calculation. On the other hand, hopefully you know about the primary care exception, which means you could have 1 clinician supervise 4 residents at the same time and be able to bill for them. And so if you have 4 residents coming, you're getting, even if they're only doing 1 visit an hour each, you have 4 visits for that hour under 1 clinician. So usually there are agreements that go with this, and again, it's very important to have those reviewed because the school sends it to you, and it's typically, or the hospital sends it to you, and it's typically one-sided towards them. And so you want to make sure that you have rights in there, like that they'll train the residents, and that you can remove the residents, and they'll do HIPAA training and things like that. Okay, billing agreements. So I'm going to combine billing with the next one, which is IT agreements. There are many, almost every FQHC has an EMR, hopefully, and is using an EMR for that. But many FQHCs also contract for billing. So you need to worry about HRSA standards and other compliance standards, right? If you're signing a billing agreement that has not been reviewed by an attorney, then you're almost for sure signing away your life. If there are things in there that are going to be terrible for you, and we see all the time, okay, so they have the ability to bill. The billing company does physician billing. That's great. What do they know about RAP billing? Right, so depending on which state you're on, right, some states you just bill the enhanced reimbursement up front, but many states you have to bill a RAP payment, and for state to state that changes. So we see all the time, both with regard to billing vendors and with regard to IT vendors, yes, my system works. Of course, I have 100 FQHCs who are using it, but that's great. Do you have any in my state, and have you submitted RAP payments in my state using your system? Inevitably, the first time they come into a state, and maybe the second and third time, they say, yes, of course I've been doing it. It's no problem. We have never experienced a new IT vendor coming in, new to the state, where you didn't have a problem. And what we tell people is when you have a new vendor, you got to build in lower productivity and lower dollars being collected for at least 6 to 12 months. But you need, in order to deal with that, you need to negotiate up front. Sometimes you can negotiate for them to give you an advance. Sometimes you can negotiate lower fees for the first year and higher fees for the second year when you're collecting more. But all those provisions need to get into the agreement to make sure that they are complying. You also need to be worried about, do they have a compliance program with regard to their activities to make sure that they're checking on, coding, they're checking on things they're doing, and that they've complied with all state laws. Some states require billing companies to be registered and make sure they have that compliance. Okay, IT agreements. So I don't want to just pick on EMR, right? Many of you have UDS add-on systems, the financial and accounting systems. HRSA is looking at this a lot more than they used to. So if you're using a commercial product that someone who, I don't want to give names, but use a commercial product that your local candy store on the corner would be using the same thing for your financial information, HRSA is not going to be happy with that. So you need to make sure you're using a system that is sophisticated enough to be able to do what you're doing, and that, again, you have those agreements reviewed to make sure that they have the appropriate information, they're compliant, the information is kept secure, and very importantly, both with regard to billing and IT, because we get this all the time. Okay, I like the contract terminated. How am I getting my data back? So then give me my data in some format that they choose. But my new IT vendor can't use the data in that format. Now what do I do to be able to get into the new format? I have to hire a third company to be able to go out and convert the data and spend thousands and thousands and thousands of dollars to be able to do that. So you want to build into the agreement that at the end they'll give it to you in a format that works for you, not just in a format that works for them. And then for the billing agreements, what are you going to do in terms of the billing that went in before you terminated the contract and hasn't yet been collected? Who's going to follow up on that? And again, how are they going to transfer your data? All of that needs to go into the agreement. Okay, the last category that I'm going to talk about is lease agreements. So lease agreements, we most often see that people say, I'm going to go to my real estate attorney and have my real estate attorney negotiate it. And I understand that for most of the time, I understand that, except for the problems that we started to see in the last year, why I tell you I think you need to go to an FQHC attorney for it. So many agreements, right, when you know that when you're opening a new site, if you have a state that has a licensure, you need to get a licensure from the state. Besides that, you need to get your HRSA added to your scope. So let's say you have an agreement that says the agreement goes live on this day and does not have built into it protections for state approval and federal approval, and now you don't get one of those approvals. Now what? So we have a circumstance right now, we have two different clients who are in exactly that situation. The attorneys did not put in the right language, and now they are stuck in 20-year leases, which could bankrupt them because they did not build in those contingencies. And so you need to be really careful for that. Right. Also, sometimes you need a notice of federal interest. You need to make sure that you're doing that appropriately, and you have someone who could explain that to the landlord. Okay. There are other agreements that I just threw up here, which we didn't get a chance to get to, but if anyone has any questions or wants to follow up, we're happy to answer questions. So given that it's 3 o'clock, like I said, I didn't think we were going to get to the questions, but if you want to submit them either directly or you want to email me, on my email's up on the screen right now, and we'll be in the slides when you get them. We'd be happy to answer any questions that you have. Thank you for listening.
Okay, everyone. Well, thanks so much for joining us. Like Jeff mentioned, we're out of time to take live questions. We do have questions that were submitted. What we're going to do is send those on to Jeff, then he can answer. Some of them were answered in the process of the webinar. And so again, feel free to email questions directly, but we'll also be sending Jeff the list of questions. And we want to be sensitive to your time, and so we will go ahead and wrap this up. Thank you all very much, and have a great rest of your afternoon.